My friends, I'd like to spend a few minutes with you sharing my personal beliefs regarding healthcare and family medicine in New Jersey. I hope then to put you at ease by spending a short time talking to you about the priorities and strategies of the New Jersey Academy of Family Physicians, which reflects the collective wisdom of the board. And finally, I want to discuss with you why it is so critical to have as many of us as possible engaged in activities to support family medicine in New Jersey. But first of all, let me tell you how honored and privileged I am to be a family doctor. I'm in a profession and a specialty where I get to help people and where I get to have 20 to 30 meaningful conversations each day. In today's world, meaningful use of EMR technology is important, but let's not forget meaningful relationships. As you know, the so-called road specialties are in hot favor now: radiology, ophthalmology, anesthesia, and dermatology. Well, let me tell you, unlike radiology, our patients actually know who we are. And unlike ophthalmology, our patients can see us when they walk in the room because our eyes aren't already dilated. Unlike anesthesia, our patients can remember who we are. And unlike dermatology, we get to take care of conditions that are more than skin deep. Furthermore, there's no 30-year crystal ball to predict financial performance of a particular specialty over the course of a career. Who would have thought 10 years ago that cardiac surgery residency positions would go unfilled? Who would have thought 5 years ago that cardiologists would be flocking to employed positions in hospitals? We need to educate students to make these decisions not with a calculus based on a faulty 30-year crystal ball, but more with their hearts and more with a reflection on why they went into medicine in the first place. But if they did want to make it with a calculator, I would tell them that if family medicine were a country, that all of the leading economic indicators are trending positive. Our fill rates in residency slots have gone up. More American medical grads are signing up for family medicine. Just last year, the ratio of income of primary care to specialty care increased from 53 to 62% in just 1 year. We have Medicare payment reform, PCMH programs, ACOs, who desperately need us, all coming into play in the next few years. Most importantly, patients now and always will highly value our services. Although the concierge model of care is somewhat controversial, and we understand that it's not a national solution, it has shown us, it has shined a bright light on one thing, and that is that patients highly value the services that we provide. Can you imagine patients paying $1,800 a year for the purposes of having a personal radiologist? I believe these are strong arguments and points that we need to make to help deprogram medical students. During the next year, I personally am willing to speak to every third-year and fourth-year student in New Jersey and convey this message, either in person, by phone, or electronic media. I'll even learn how to Twitter if necessary. Oh my God is right. I believe that those on the board and those in attendance today are also willing to convey this message. So for those of you that are involved in undergraduate medical education, sign me up and sign up others in this room right now to convey this. Last year, in May, the journal Health Affairs came out with a landmark edition totally devoted to the concept of the patient-centered medical home. It was entitled Reinventing Primary Care. And although it was the largest volume that they ever produced and had numerous key positive results, there was something that was disturbing to me about that article. In 1972, when I was starting my third year of medical school, I saw a blurb on the news about reinventing primary care. It featured Hunterdon Medical Center's family practice residency. I had never heard of family medicine, but the next day I enrolled at Rutgers Medical School, soon to become Robert Wood Johnson Medical School, largely because they supported this concept, and I thought that it was for me. It's a decision that I've never regretted, not for one single day. Now, about 15 years ago, I and many others who were involved in family medicine education at the time mistakenly migrated to the managed care industry, thinking that that was going to become the second reinvention of primary care. And for a short time it was. Now we have the patient-centered medical home and the third reinvention of primary care. Now, no one is more bullish on the patient-centered medical home than I am, and no one is more passionate and optimistic about the future of family medicine than me. But one thing that I do not ever want to see is a need for a single article, much less a journal, devoted to the need to reinvent primary care for the fourth time. We have to get it right. We have to get it right this time and make it stick. Anything less than a total and permanent revitalization of primary care will be vastly detrimental to the citizens of our country. Spain completely and successfully rebuilt their healthcare system around primary care. The city of San Francisco successfully redesigned their safety net care around a network of private, public, and charitable patient-centered medical homes. New Jersey deserves no less. But while I'm very optimistic, this is not going to be easy. We have to pick our battles carefully. One battle that I personally do not think we should pick is with nurses and PAs over independent practice. I know this is not an opinion that is shared by some of the colleagues that I respect the most in this organization. And there are serious arguments on both sides. However, organizations like ours need to focus energies and limited resources on our greatest priorities and where we have the greatest leverage. I'll also point out that we can't ignore the tidal wave of the shortage of primary care physicians in the next 20 years, which we primary care physicians cannot possibly hope to fill. As the medical futurist Jeff Goldsmith pointed out, we have the triple whammy of the aging baby boomers who need and demand more medical services, the retirement of a workaholic generation of physicians that I represent, and a small number of new entrants into primary care who are of a generation that wants to trade off financial benefit and productivity for lifestyle gains. In that situation, making an argument that to restrict nurses and PAs is a difficult one, even if we know that they may be more productive in a collaborative arrangement. Now, if we do want to do battle, I would suggest that we do battle with the hospital specialist alliances, which have systematically eaten our lunch and patronized us over the past 75 years since the creation of Blue Shield, which was created by hospitals to give proceduralists a steady income if they admitted patients to the hospital. 3 years ago, I spoke at this meeting and stated that the next battle that we were going to face was on income redistribution. We've seen the AMA state that they support the patient-centered medical home model, but only if increased payments do not come at the expense of specialist compensation, and with the proviso that specialists can function as medical homes. In the last 2 decades, this beatdown has come in the form of the Relative Value Scale Update Committee of the AMA, alias the RUC. There's been discussion at the AAFP board that we should withdraw from the RUC, and it's a move that I support. However, even this may represent yesterday's battle. With credit to Bruce Bagley for articulating this concept, we have to understand that the battles with specialists over fee-for-service payment schedules represents a battle of redistribution in a productivity-based model. The best we can do in that situation is to get a little more and specialists have a little bit less. This is never going to be enough to reduce the income gap to where we get students to go into family medicine in any way, the numbers that we need. In fact, it's going to perpetuate the excessively undue administrative burden that primary care physicians bear. To quote Bruce, reapportionment of RVUs does not constitute reimbursement reform. What we need to do is to promote and create reimbursement mechanisms that are hybrids of fee-for-service management fees based on covered lives, which allow us to build the necessary infrastructure, and then rewards based on the incremental outcomes that we create. Well, enough about battles. The good news is that I believe that we have the tools directly under our own control to make it stick this time, and we don't need to rely on regulators, legislators, and other external constituents. Those tools are practice transformation, consolidation, and realignment. Now, to do this, we have to realize that it requires change, and this change can't be cosmetic. Even for those of us who started on this path of practice transformation years ago, we must understand that this process of transformation is constant. Standing pat and continuing in the tradition of traditional practices that are not integrated and are in small units, I believe, is a risky strategy and one that is not sustainable. I tell you this as a solo practitioner who values my independence but understands that I need to be part of a larger and more clinically integrated organization. Now, my golf instructor, my first golfing illusion, in commenting on my golf swing, reminds me that Einstein said that the definition of insanity is continuing to do the same things over and over again and expecting different results. This also applies to how we run our practices. But change is not necessarily bad. The Chinese have a word, jiwei, and jiwei means two things. It means danger, and it means opportunity. We can look at the advent of the PCMH and accountable care organizations as either. Personally, I view them much more as opportunities than threats. Danger to me is standing pat and treading water. Now, one major advantage of engaging in practice transformation and practice realignment is that it gives us a better control of our own destiny. The group practice of Puget Sound data showed that one of the most important outcomes was the reduction in burnout. This should come as no surprise to us as family physicians, and we can make a strong comparison to the outcomes of our own patients. Stanford researcher Kate Lorig was primarily responsible for identifying this concept that patients who have a good sense of their ability to control their own illness, what she termed self-efficacy, have better clinical outcomes than those who are passive and rely on externalities to treat their illness. To me, the idea that we should wait and not transform our practices until some way either legislators or regulators force insurance companies to pay us more is not only unrealistic and dangerous, it's similar to patients with chronic illnesses who don't think that they have any capacity to control their illness. Now, part of the reason that many of us who are involved in practice transformation and practice realignment are more optimistic is that we feel that there's a path for us to emerge from the hamster cage, and that this is something that is under our control. Now, I know personally that this transformation is exhausting. There are many Friday afternoons where I have nothing left in the gas tank whatsoever, and I'm praying that we don't have a work-in at 3:45. But that exhaustion is cured with a good night's sleep, and I always look forward to Mondays. If all I saw in my future was continued hamster care, I fear that all I would look forward to is Fridays and that I would dread Mondays. Now, as many of you know, I worked on the dark side for 7 years, and I'm still repenting. But that experience did give me an appreciation for how healthcare insurance companies think and operate. Many of us feel that we cannot trust insurance companies. I would say that independent of what insurance companies say, we can totally trust how they behave. Most of them are for-profit, publicly traded organizations, and as such, their activities are totally aligned with their corporate responsibilities, namely to maximize shareholder equity. This is the economic and political system that we operate in, and it's folly to think that they should behave otherwise. As such, we cannot hold them accountable for social engineering to do, among other things, improve the foundation of primary care in the United States or in New Jersey. It's simply not their role in the healthcare system that we operate in. That responsibility falls to consumers, employers, legislators, regulators, and public policy advocates with our strong voice in the mix. Furthermore, if the responsibility of insurance companies is to shareholders to maximize return on equity, then they're going to use all the tools that they feel comfortable will work, and they're not going to use tools that they feel uncomfortable with, and they have a very short time horizon due to the need to produce quarterly reports to investors. Specifically, they are not willing to pay more to one segment of the healthcare system on the theory that somewhere down the line they might see profits, unless they can have hard dollar offsets from another segment of the healthcare system. They will continue to use tools to control costs that they feel confident work. And the best tool in their eyes is to ratchet down provider payments. Now, negotiating theory teaches us that the best way to create a win-win situation is not to focus on distributive issues alone. I get a bigger piece of the pie, you get a smaller piece. The only way to expand the size of the pie in healthcare reimbursement is for providers to create systems of care that reduce total medical costs. And that's especially true in New Jersey, which has among the highest costs in the nation. As long as we continue to be among the most fragmented healthcare delivery systems in the nation, and not coincidentally among the highest cost, we can expect that physician payment will be among the lowest, and that family doctors will get caught in the crossfire. So I believe that we need to see a realignment of primary care in New Jersey to reduce fragmentation. There are two compelling reasons for us to achieve better integration, either vertically or horizontally. The first is competition. Competitive strategy theory teaches us that purchasers try as much as possible to consolidate and keep suppliers fragmented. And suppliers, on the other hand, would like to be consolidated while having the purchasers fragmented. Health insurers are aggregators or consolidators, and they purchase access to health care providers on behest of the employers. We are the suppliers, and unfortunately, we are a textbook example of what happens when purchasers are consolidated and suppliers are fragmented. And in the context of healthcare, of high healthcare costs in New Jersey, most employers are happy to see insurers doing the market consolidation while we are doing our part by remaining fragmented. Indeed, Walmart would be envious of the market clout that insurers have in New Jersey with providers, and we've created it by remaining fragmented. The second compelling reason to integrate is product differentiation. In terms of creating better systems to improve healthcare access and drive down healthcare costs. In doing this, whether vertically or horizontally integrated, we will need to figure out ways to work collaboratively with hospitals and specialists to figure out better systems of care. So we have options. We can be like Vlasic Pickles, who was persuaded by Walmart to give them gallon pickle jars at a price so low that Walmart could sell them at $2.97 a gallon. They were very good pickles, very popular. And Walmart sold so many of them that Vlasic went out of business. Or we can be like Procter & Gamble, which is not only large, vertically and horizontally integrated, but they also are operationally efficient, and they have differentiated products that Walmart feels that they cannot do without. People buy Pampers, they do not buy generics. We can create systems of care so good and so well differentiated that neither employers, insurers, or patients will feel that they can do without us, because not only have we created the value, we have measured it. Practice transformation, consolidation, and realignment, I believe, is our ticket to control our own destiny. Now, I know that there are many of you that are leery of change and either say that they refuse to transform their practices or will not do so unless and until there are dramatically higher fee-for-service payments. Unfortunately, I think that this is a very dangerous form of chicken, and furthermore, to outsiders, it sounds a bit like whining. To quote our colleague Margie Harbrecht from Health Teamworks in Colorado, either we can continue to act like victims or we can take control of our own destiny. More pointedly, I'll quote from one of the greatest philosophers of the 20th century. And although you may not recognize the poem, you will certainly recognize the author. "I'm leaving," he said, "leaving Salisalu on the banks of the beautiful River Wahoo, where we never have problems, at least very few. And I'm off to the city of Bulu-Bu-Ball, where they never have troubles, no troubles at all. Come on with me," he said as they ran, "and you'll never have any more troubles, young man." That's what the man said. So I started to go, but I didn't. Instead, I did some quick thinking inside of my head, and then I started back home to the Valley of Vung. I know I'll have troubles. I'll maybe get stung. I'll always have troubles. I'll maybe get bit by that green-headed quail on the place where I sit. But I brought a big bat. I'm all ready, you see. Now my troubles are going to have troubles with me. We have a lot of opportunities, and right now, our stock is high. There's already a lot of activity going on in New Jersey. Hospitals are buying up practices, practices are merging, ACOs are being constructed. We need to be careful in the choices we make, but we should not be afraid of metamorphosis, and there's no single answer that's right for all of us. Now, that change also brings opportunities and threats to the New Jersey Academy of Family Physicians. A new generation of physicians have different values than those of my generation, and we're not going to change that. As a group, they are less entrepreneurial, but on the other hand, they're more likely to want to work in a team environment and as an employee, as well as to have a better balance between their personal and professional lives. The membership of the New Jersey Academy in the future will be dominated by physicians who are employed either by academic institutions, hospitals, or large groups. In that scenario, many of the services that we currently offer may be less relevant to this population, but there may be other needs that we can meet. We should not look to physicians migrating to employed status as a failure, but as simply another change that we need to adapt with, and one that's governed more by generational changes in values than local economic issues. To address this, I'm creating a task force on young and employed physicians chaired by Robin Schroeder and Lauren Carruth. Those of you who would like to work on this, please speak to either myself, Robin, or Lauren. Now, if there are elements of what I've said that make you feel uncomfortable, let me reassure you that these are my personal opinions only, and they do not represent the positions of the Academy, which either are created by this House of Delegates or by the board. The responsibility of the president of the organization is not to create policy, but to be an effective spokesperson for the positions of the Academy and to make sure that he or she hands the organization off in a little bit better position than he inherited it. And to that extent, I would like to thank Tom Ortiz for doing exactly that, and I hope to do the same for Sal Bernardo. Around you, you see the strategic plan that was several years in the making. I'd like all of you to look at it again. As you can see, these tactics and goals are ambitious, but they're also necessary, not only for the New Jersey Academy, but for our membership. There's no way we can achieve these goals without the active involvement and participation of each of you and of our entire membership. Collectively, we have the capacity to produce enormous achievement. Friends, professionally speaking, I'm on the back nine. I'm probably somewhere around the 15th hole. I've got about 3 holes left, and I'd like to see a couple birdies. By the time I get to the 18th tee, I'd like to see the entire course filled with energetic family physicians who feel in control of their own destiny, who feel valued for the contributions to the health of the citizens of New Jersey, and who always look forward to Mondays. To do so, I need your help, and the New Jersey Academy needs your help. To quote Anne Frank, how wonderful it is that nobody need wait a single moment before starting to improve the world. Thank you.
Thank you, Bob.